Well, good afternoon, everybody, and thanks for joining us. Today, you've joined us for the Los Angeles County Emergency Preparedness Updates. Generally, if you're not familiar with this, we try to CAF has a consultant, as well as myself. We try to attend every DRC meeting in the county, and we collect all that information and we try to put it into a webinar so that you guys, if you don't have an opportunity to go to the DRC meetings, we collect that information and then pass it out in this format. Sometimes it makes it easier. That way you don't have to drive to a hospital to go to the DRC meetings at a specific hospital. So today is May 18th. It's 1 o'clock in the afternoon, and we're going to concentrate on a few things. I'm going to bring you a couple updates that we've heard at the DRC meetings, as well as point you to the Los Angeles County section of our website. If you're unfamiliar with the term DRC, or Disaster Resource Center, that's what DRC stands for. In Los Angeles County, there are 13 DRC hospitals, meaning those hospitals are set up to be a hub to support emergencies and disasters within a geographical area around that hospital. And so us as skilled nursing facilities, intermediate care facilities, the Clinics Association, hospice, home health, all those folks, dialysis, we're all tied into that kind of DRC. And that DRC does a lot of stuff that helps us kind of meet our CMS emergency preparedness requirements. So it's really important that we at least attend and get our attendance logged, and we keep a record of that information for survey and stuff like that. That's obviously will get us past the survey point, but there's a lot of good stuff that comes out of the DRC meetings. Not all of the DRC meetings are set up for just skilled nursing care, for sure. It's almost, well, I don't want to say exclusively, but it's 90% geared towards the hospital folks. But there are things there that we need to participate in so that we can get that information, one, to help us meet the CMS requirements, but two, to kind of build those relationships with the folks that are likely to be the ones helping us during a disaster. All right, so my name is Jason Belden. I'm the Director of Emergency Preparedness for CAF. The consultant I was mentioning was Rich Widorinsky. Many of you that have been with CAF know Rich. Rich is a former administrator who's retired now, who has a passion for disaster preparedness and disaster planning in skilled nursing facilities. And he attends those DRC meetings, and he's a wonderful advocate for us. That kind of speaks from a knowledge-based perspective when they talk at DRC meetings. So we really appreciate him going and representing us. Rich wasn't able to join us today, and we've got a tight schedule. Normally, I would have Rich come on and give some brief updates, but I'm just going to give you a few of those before we hop into our main topic. And then Summer Brazel is the new Disaster Preparedness Program Coordinator at CAF. And Summer, you want to say hi and introduce yourself?
Hi, everybody. This is Summer. As Jason said, I'm the new Disaster Preparedness Program Coordinator. I came on with CAF in January, and my background is a lot in public health. I work for the Oregon Primary Care Association before moving back to California. So I'm excited to join the team. Thanks, Jason.
Yeah, thank you very much, Summer. And for those of you guys that remember Courtney, Summer's filling Courtney's position. So a lot of the stuff that kind of the administrative stuff that goes with the classes and stuff that we teach, attendance to the meetings and things like that, where you need something from CAF, please put her name in your Rolodex or your contact list. Certainly, and she's going to be hopefully here for a long time helping the providers out. And just so you know, anybody at CAF, if you ever need to get a hold of us in terms of email, the easiest way to remember this is our first initial last name at caf.org. So for any of us, that's generally the easiest way to find us. So please don't hesitate to reach out and say hi, introduce yourself. Many of you will get to know Summer over the coming months. So let's talk just for a second before we hop into our main topic, and just mention that at the beginning of every calendar year, all of the DRC meetings do a process called the Hazard Vulnerability Assessment process. And what they rely on is they rely on each one of the facilities that are within their catchment area, or their jurisdiction, to provide them a copy of your hazard vulnerability assessment. Now, hopefully you're familiar with that term, hazard vulnerability assessment, or a risk assessment, or hazard vulnerability analysis. There are a lot of different terms for it. HVA is a pretty common term, so if you refer to it by that, most folks are going to know what they're talking about. But at the beginning of the year, every year, you should be revising and updating your HVA, and then supplying that HVA that you have updated every year to your DRC coordinator. And that DRC coordinator is going to use that information to build a community-based HVA that then you will get a copy of for CMS emergency preparedness requirements. So a part of the CMS EP regs not only require us to do our own HVA and have that documented in our plan, and it has to be updated annually, but we also have to have that community-based HVA, and that you can get it from other jurisdictions, but certainly this is the one that's most applicable to healthcare. And it will also, if you're going to the DRC meetings and you're going to the HVA meetings at the beginning of the year, you'll learn that some people may have insight into certain types of disasters or certain types of risks that you weren't aware of. So it may help you build a more robust look at the type of risks that your facility is likely to face. So if you've not been involved in that process, but you still want a copy of your HVA for the DRCs, on our website under the Los Angeles County section. So if you go to cafdisasterprep.com, on the right-hand side, there's a tab that says resources. And if you look for the resource that says Los Angeles County, if you click on that, it should have a list of all the DRC coordinators' contact information with the proposed meeting dates for the remainder of the year. And obviously, this is subject to change. We are still slightly activated, or partially activated for the COVID response. You guys more so maybe than the hospitals, but the hospitals are definitely still doing some form of incident command or modified operations. So the dates could be subject to change, but definitely, give your DRC coordinator a call or email them and ask them for a copy of that HVA. Okay. Now with that, I want to hop into our main topic, and that's about after action reporting and improvement planning. So I've done a number of these presentations on, kind of how to do the after action template. I want to talk about the template that we've included as a handout and how you use that and where you gather the information within the handbook that the federal government has provided. So just so you know, the format that we use is a national standard. It's for the Homeland Security Exercise and Evaluation Program. But these templates, or that format for the after action report and an improvement planning, is consistent across almost every kind of agency you can think of. So, OES and CDPH and your local health department, they're all going to be doing an after action report in the same kind of format. And they're going to be looking at the same categories that we're looking at. Now, these core capabilities as defined in that handbook, there's a ton of them, right? What I want to do is these core capabilities apply to everybody in healthcare, from public health all the way down to home health. And it's everything in between. Institutional care, home-based care, community care, everything is included in here. So it's a 500-page manual that really I don't expect you to read this. The reason why I wanted to include this is because it has information on each one of these sections where you can kind of look at, well, okay, this is where it applies to me, and this is the section that applies to me. And I've tried to pull that stuff out and put it into this, into the template. And I'm going to show you, kind of where you're going to gather the information out of the handbook, and then what information from the template you can remove and what you need to add in. So one of the first things we need to do is there are four capabilities, four core capabilities listed in this handbook. All of the actions that we're going to talk about in this after action report are going to fall under one of those four categories. Those four categories are foundation for healthcare and medical readiness, healthcare and medical response coordination, continuity of healthcare service delivery, and medical surge. And those are big kind of overarching topics. And then there's stuff within there that we're going to want to focus in on. And I'll tell you kind of the things I think you should, or were most commonly probably strengths and weaknesses, and we'll get to that in a second here. But the objectives and activities that are listed out are things like, did we identify risk and needs? Maybe we did, and that's a strength, and we can list out the processes we took to be able to maintain that situational awareness about what the risks are and how they're changing and what our residents' needs are and our staff's needs are and our facilities' needs are in order to meet the response. Maybe you've identified that as a strength. That's great. And maybe it's both a strength and you discovered some weaknesses. We're going to capture all that information, and I'll show you how to write that out. So things like coordinating our response strategy or distributing resources required to protect the healthcare workforce. This is a real tough one, guys. This is one, I think it's universal that not you guys as facilities, but it's us as society. It's us having a stockpile of equipment to be able to deal with that. It's dealing with conflicting information about what the right type of protection is. There's just a ton of stuff that goes into how well we did at distributing resources to protect our workers. But I honestly think this is something that we really need to concentrate on. And the good news is, not good news, but one, we know that there are some regulatory things coming down the pipe that are going to really require you to have your own cache of PPE on site. And so in terms of an improvement plan, this one actually has some really easy fixes for that you're going to have to do anyway. So if you look at it from a backwards side, we've got the work plan to figure this, or we're going to figure this out no matter what. Let's capture it as a part of our AAR and improvement planning. So, all right. So this is when I talk about the capabilities, the objectives, and the activities, when you look at the template that we've provided, this is what I'm talking about. And I've listed out just about every objective and activity that I think is applicable. It does not mean, absolutely does not mean you have to do all of these. As a matter of fact, I highly recommend you remove 90% of these. The point is, you're going to have to figure out, what do you think you had strengths on, and more importantly, what improvement plan do you want to concentrate on? What, after doing your analysis of your after action review of the strengths and weaknesses of the things you've identified, when we look at the things, what's the improvement plan that's most likely to lead to less loss of life or less impact to our operations, things like that. We want to take big chunks and go at that. And I think the PPE one is definitely 100%. It could be in the improvement plan. You say, I'm going to have a 45-day surge supply of PPE on site. Now we know that's going to be a requirement in 2023, so it makes it a great improvement planning thing, because you're going to have to accomplish it no matter what. So in terms of these things, the way you're going to do this is you're going to leave the capability for whatever objective or activity you're going to do. You're going to pick the objective and the activity that you want to concentrate on, and then you're going to remove all the other stuff. And really what we all want to do here is we need at least 3 objectives that we're going to look at. And so we need 3 of these items that we kind of need to look at, whether it's identify risk and needs, and within that, did we assess vulnerabilities and risks? That could be one. Healthcare medical response coordination. utilize information sharing procedures or utilize communication systems and platforms. That's a good one, that utilizing communication systems and platforms. And we think of it in terms of how did we respond or report information to the health department. But I also think about it in terms of, you know, how hard was it or how difficult was it for you to have a constant chain of communication with family members and members of that had questions of the media or things like that? Did you develop a communication system, or did you purchase some type of communication system like a mass text, or did you utilize listservs or other things like that that will help you in the future with providing instant communication to your resident family members? Because the requirement to communicate with families during disasters applies across the board. It's not just during the pandemic. So if you have developed a system during the response that allowed you to communicate better and have less, less actual taking, staff away from providing care to be able to meet the needs of the communication requirements. I think if you did that, those are great strengths you would want to list out, and an improvement plan on that it's actually already complete. You've already completed the improvement plan. You could say during the response, we noticed that we were taking staff time away from providing care to be able to just answer phones and meet the needs of the family members. That's a very labor intensive process that if you in the middle of the response changed it and you implemented an improvement plan, that can be included in your AAR and IP. It does not have to mean that you have not completed the improvement plan. If you've already done all that you needed to do to improve that item, that's what we're going to capture in the documentation. So we want to make sure in this section we only keep the 3 or 4 or 5 or however many you want to look at, but only at least 3. We're going to keep 3 of those. We're going to remove all the rest of this stuff when we do this. And the template's in a Word format, so it should not mess up the formatting to just remove those things. It should leave it pretty consistent. All right. In terms of the objectives you choose, it's highly likely that the incident and objectives, unless you're really familiar with this process, you may not have written them out that way, or you may not have verbalized them that way. That's fine. When we're talking about this after action report and improvement planning, we're really working with a set, kind of guidance document that everybody's using it from. And so maybe their objectives were slightly different, but when we talk about this AAR, we want to keep them in these same categories. And the reason being is that way we're, hopefully at the end of this, we're all comparing after action reports, the facilities, the health department, CDPH, the MOOC, we're all looking and talking about the same thing. So we can all kind of gauge, are we accurately reviewing our performance? Did we really do as well as we thought we did? Or did we more poorly than we thought we did? Things like that. So I'm going to show you what the section looks like in terms of scoring, and I'll talk to you, tell you what that kind of scoring performance means. I mentioned we're going to choose 3 at a minimum, and we're going to provide kind of a narrative statement of what we feel our strengths are in that objective or that activity. What were the strengths that we identified in doing this? Did we identify we had a strong incident command team, or did we identify we had a great, I don't know, we had a great maintenance staff who understood industrial hygiene and the role of airflow in indoor environment, things like that. Those would be like tangible strengths. Another strength could be we participated in each and every opportunity to learn from our health department, or from CDPH, or from CAF, or from HSAG, or the ECHO group. One of the those objectives is to maintain that situational awareness. And during this response, it's been absolutely critical that each facility have almost daily really kind of interactions with the CDC or CMS or HSAG or CDPH or local health department or us or the ECHO group or infection preventionist meetings. All of these things were bringing situational awareness in the form of subject matter expertise as well as regulatory requirements. So if you identified that as a strength, you had a daily process or a every other day process to take that information and incorporate that into operational plans, that could be a big strength. If you said, look, I listened every Tuesday, Wednesday, Thursday, Friday to the information passed out. I incorporated those changes into my mitigation plan the minute I heard it, or I took it to our incident action planning committee, and then we put that into effect. Those would be an example of a strength you would want to document. In terms of an area for improvement, this should just needs to state what the problem or gap is. I mentioned one was an area for improvement would be we didn't have enough N95 respirators on site, or what's more likely is we had not fit tested folks prior to the pandemic. Now, there was no regulatory requirement for that, but it certainly would have helped had your staff all been fit tested prior to the event. For sure, it would have made it a lot easier for you if you had done that. So that could be an area for improvement. It doesn't necessarily mean that you should have had clairvoyance and figured this out first. It just means that that's an area for improvement. We know where the improvement needs to get better, and then that's another one there where you can go, that's a really easy improvement plan, because an improvement plan would be just to purchase our own qualitative fit testing equipment, train 3 or 4 of our staff, have them watch the CAF video on how to do qualitative fit testing. And now you've got a kit and you've got multiple people that can train, or multiple people that can onboard or take any new staff member and immediately perform that qualitative fit testing process. That would be an easy improvement plan for you to kind of purchase the equipment, train the staff, wouldn't cost you a ton of money, and then you would be all squared away for next year or 5 years from now. You'd be ready to go with getting any remaining staff not fit tested into the process. So that's a good kind of tangible improvement plan. In terms of the reference, in the document, it asks to reference or list any plans, policies, procedures, regulations, laws, anything that's in reference to the objective and the activities that you have highlighted. So in the case of a strength, you could say, we developed, or we constantly evolved our mitigation plan, and this was a process we used to update our mitigation plan. That could be a strength, and then the reference is the actual plan showing when it was updated, maybe a documentation of the process that you used to update the mitigation plan, things like that. As well as the AFLs that were in effect at the time, so you'd want to keep those with the reference document that apply to the objective that you're looking at. And then the analysis is the last part, and that's where you're going to provide a root cause of what your analysis is, not anybody else's analysis. This is, you get to pick this, what the root cause is of why anything was not achieved. I don't want you to point a finger at yourself, but we definitely want to say, in the case of the fit testing, we could say there was no regulatory requirement of the providers to have all care staff fit tested prior to this pandemic. We also know that there was not access to fit testing resources at the beginning of this event, and so So even though those are failures, they're not necessarily failures within you necessarily. Um, it's more of a failure in an understanding of where the process was, and frankly, a failure of OSHA and CDPH to mobilize those resources, especially after we had brought it to their attention back in April of 2020. So there are things that are outside of your control. It's fine to document those things in the analysis if that's what you want. We want to definitely capture failures in systems, because we don't want to repeat those mistakes. But I don't want to get into the thing where you say this is everybody else's fault. Whatever your analysis is, we want to take ownership of what we can do to change. And so if there's a part of that analysis you go, gosh, man, I can do this better, make that a part of your improvement plan. Or this is the part of the process that I own and that our facility can do to make it better. All right, so in terms of the improvement plan, when we get to the improvement plan, I'm going to show you kind of a picture of what that looks like and how to document. All right, so let's take a look at we talked about the scoring of things and the analysis of the core capabilities, but in the template, it asks you to give yourself a score. And so in the areas where it's grayed out, the expectation is you're going to type in whatever objective that you've chosen and what core capability it lines up with. And then over here, you're just going to give yourself a score. Did you perform this objective without challenges? All the way down to you were unable to perform it at all, right? That's kind of self-explanatory. There is a ratings definition that gives you a description of how you should be rating it. So if you want a little more description of like the nuance between the categories, there's a description right under that. Now, you don't have to remove that information. That's kind of standard languages that's on all of these after action reports. All right. So when we talk about, the kind of the things that I think we should be looking at, and these are the ones I want to kind of, walk through with you guys that I think are important, but they're not, maybe they're not 100% what you guys think are important. But these are the ones that I think we struggled with. How to assess resources within our community. So I can't tell you how many folks that I spoke to that did not know how to order resources and supplies from their MOOC at the beginning of this. And that process has been in place since well before I started working for CAF or doing disaster. So that process has been in place for a while. So I would say that is definitely, now if you've developed that process and you've signed up for the Salesforce thing and you've ordered resources from your MOOC and you've got that down, it sounds like you've got your improvement plan already figured out. But this is one of those things that if you had not and still struggle with accessing resources through that MOOC system, this is one of those things we should definitely have on our list. And if you have a MOOC who has been less than resourceful or less than helpful throughout this, we want to document that too. There may be some things in our improvement plan, that we can take ownership of to build that relationship with those folks. If it's a relationship management issue rather than a resource issue. I know it's hard to kind of divide those two out, but really I've dealt with not all of them, but most of the MOOCs around the state. Gosh, these folks just want to help, and when they're they're supposed to be the provider of all these scarce resources during disasters, when there's a large event like this and everybody needs resources, then we find out how limited this system is. We all rely on mutual aid from each other, and that sometimes that mutual aid comes from a different city or county or region, but somebody within our state comes to help or has resources to supply us. But when everybody's out and everybody's hurting, then those resources become much harder. And so that became a really, really difficult thing to overcome during this event. And if you had identified, gosh, man, I couldn't get any resources, and this is the lengths I had to go through to get my own resources. And that's a strength. That's resilience. That's moving past the can't perform at all into I don't care. I'm going to do what I can to get my own resources, or I coordinate with a sister facility down the street who has, they have 100 gowns and I have 100 masks, and I swap them or something like that. Those kind of things would be strengths that you would want to highlight. In terms of like the healthcare and medical response coordination, the utilization of the communication systems is really, we hear from all different folks. We talk to providers all day long. Obviously, we represent you guys, but we also hear from families and advocates and folks like that who have talked about really the difficulty during this event to get information from facilities about the status of their loved ones. And if they weren't calling a lot before, they're definitely calling a lot more now, because they're very concerned about the safety of their loved ones, and with appropriate measure of concern, I would say. In terms of identifying information and access and data protection procedures, there's a lot of things that go in with how we shared information across spaces that we could take a look at. But really, I think mostly we want to concentrate on, did we get the information that we needed to get in a timely fashion? Did we operationalize that information to mitigate the effects on our residents? Those are the main things. And then, obviously in dealing with staff injuries and things like that. All right. So when we look at this format, any of these gray sections again, excuse me, are where you're going to, obviously remove the objective, and then you're going to write in whatever objective you've identified on the beginning of the document, what core capability it lies under. And then you're going to list those three strengths. It's an observation statement. It doesn't have to be true, or well, it should be true, obviously, but my point is, nobody's going to grade this. This is not a pass or fail. This is kind of the process you do it, and provided you capture all this information, you're doing it correctly. Now, if you want to get into analysis of whether it's a good improvement plan or whether you were looking at the right AAR, that's a bigger conversation, and certainly not one a surveyor is qualified to answer necessarily. They may, but not always. And so as a part of the survey process, there's going to be no analysis, I don't think, and say, gosh, you didn't do this correctly. As long as it's completed, in terms of a survey perspective, you're going to be okay. I mentioned all the things that go into these categories, but strengths will list the capability level. So did you perform it with, with challenges, without challenges? That goes into that box. Under the strengths, we're just going to delete out the gray area, put our own observation, and then the areas of improvement are what we're going to put on our improvement plan. All right, let's see if I can, there we go. All right, so in terms of some of the other things is identify and coordinate resource needs during an emergency event. That's was really difficult. I'm not certain how many of you guys were doing incident action planning with your healthcare coalitions or with other providers, but if you participated in a kind of weekly or even more frequent meetings with your healthcare coalition, or with your health department, that would be an example of something coordinating incident action planning. Now, they may not have called that, an incident action planning meeting, but it may have been like an update meeting or something like that. I think technically, since they were giving you, kind of operational or response information, we would call this an incident action planning meeting, but it could go under number one. Either way, if you developed a process to do that and you participate in the process and you want to identify strengths or weaknesses in that process, you can certainly use that under that category. So in terms of one of the main things for continuity of care is maintaining key functions. So how well did we identify the essential functions within our building, and how did we maintain them? And when I say essential functions, I mean, like if just the stuff we need to provide care to the residents. And that's a pretty broad thing. That's, it's obviously it's medication, it's pharmaceutical supplies, it's medical supplies, but it's the building that we're in, it's the air that we breathe inside the building, it's the food that we eat, the water we drink, the toilets that we flush. Those are essential functions within that building. It's the fire alarm system, it's the smoke alarm system. All those are essential functions. If any one of those things fails, it could present a risk to life safety of the residents of the building. So we have to have mitigation strategies to deal with what happens when an essential function fails or we don't use it. So if there is something like that that you want to take a look at in this response, you certainly can do that. Also, were there other things that we postponed or that we moved that we had identified that were not an essential function? Things like family visits. It's sad to say that's not an essential function when we're talking about life and death. And so an essential function has to be that which leads us to preserving life and health. So, and there's certain other things that we may think are essential to the well-being of our residents. They're not considered a technical essential function. So we can look at those categories. In terms of the continuity of healthcare service delivery, that's that third objective. Within that, there's assess supply chain integrity. Obviously that at the beginning of this, it's gotten better certainly, but at the beginning of this was god awful. I mean, it was terrible, terrible, terrible. And it started well before you guys were even aware that there was a pandemic. And I don't know how many of you know this, but we wrote an article back in January 2020, and we told you guys to load up on PPE without trying to sound the alarm bell. But the reality was that back in January, that the providers were already putting you on allotments, and those allotments were based on 2019 orders, and it was a pre-pandemic order. So obviously the supply chain just took a dump. I mean, it was the worst. Certainly led to significant transmission within our buildings. Had we, used N95s as source control back in March of last year, we wouldn't be sitting in the same spot. So it's important that this supply chain, kind of gets documented. So we want to document that there was no way, shape, or form that we could have met this, right? We could not have, there was nothing else we could do to maintain that supply chain. We could purchase equipment from non-vetted vendors. Maybe you got scammed and you bought some fraudulent PPE. That happened just tons all over the place. Anything like that, you could document in this kind of category, in terms of this. And from an improvement plan, this is another one of those things where you go, okay, supply chain stinks during a disaster, especially a pandemic that affects the entire planet. If that happens again, I'm not going to rely on the supply chain to provide that initial response. I'm going to maintain my own supply of PPE. And like I said, the state has already said you're going to have to do that. So this is a great one to include in your improvement planning, because you're going to have to do it anyways. Objective 5, it talks about protected worker safety and health. How well did we do distributing resources required to protect the healthcare workforce? Obviously not great. If we're having to use or reuse N95 respirators, that's not what they're designed to be used for. So that's definitely not a strength, but it did show resilience. You could say we incorporated or we identified that we could not get enough PPE for disposable use, so we had to convert to limited reuse or decontamination or whatever it is. You can capture that information, but as an improvement plan, we want to lead back to that's not, we want to have enough to be able to meet a period of time in order for the supply chain to catch up. All right. And then one of these last things, it's quite possible that you guys have done this. And if you're not, there are tons of kind of healthcare worker resilience tools to help your staff in dealing with the stress. A lot of folks are going to have PTSD after this. A lot of you guys are going to have PTSD after this. I mean, I'm going to have PTSD after this, and I'm only halfway joking. It's been a rough year. So we want to, if we had identified within our response, God, man, we had this process where we, had a call-in line, or we directed our staff to counseling services, or we had, within our health plan, we had identified resources where we could get people to counseling or something like that. Those are examples of things that we could have identified as strengths. And if we've not identified them as strengths, it's certainly something we can do on our improvement plan to say, this is what we can do to help our healthcare worker resilience. I know there's going to be an article in CAF News that on Thursday that talks about some resources that are available for one-on-one counseling for healthcare workers, and it's mainly for care staff. I'll have to look if it would apply to like EVS staff or activities or your dietary staff, but definitely look for that. It sounds like it's going to be a great resources, and it's not going to cost anybody any money, so that's a good thing. All right. In terms of the last kind of objective that we look at, was a planning for medical surge. And when we talk about medical surges, it's up and above what we were planning on housing. So did we add beds, or did we move beds, or did we create a space for our response that was outside of where we would normally take care of residents? I've talked to a number of people that had like an activity area they turned into their COVID receiving zone, and they had divided it off, and they basically turned that into their yellow zone, and they had done negative pressure isolation, and in each one of these little pods that they had set up, that's kind of an idea, like you didn't expand your bed capacity, but you moved your bed capacity to better meet the needs of the surge. These are things like zones and setting up the staffing for the zones. Did we respond to behavioral health needs of the residents during the medical surge response? Did we enhance our infectious disease and preparedness or information during the response? So did we have a process to onboard that information? Now, this category there's really two kind of, under the first objective and this last objective, they have very similar categories. When we talk about enhancing the infectious disease preparedness, I think I've got some kind of notes I just want to talk about. But did you guys activate relevant surge plans? And when you activated the surge plans, did you expand bed capacity? Did you assess the staffing that you needed, or did you create a staffing model for working in specific zones? We want to capture that information, because that's really good stuff. If you came up with a process to kind of, almost kind of have a module of staff, and this module of staff, it's 8 staff, and those 8 staff can work in these 12 rooms, and that's that. And those 8 staff are separate from the remainder of your staff. If you develop something like that, one, I want to hear about it. 2, you definitely need to capture it, because that's a strength, and it's something we talked about early on. And then some folks struggled with it, and some folks have done better with it. And with how difficult it is to staff these zones with unique staff, any best practices we've got on that, we've got to share appropriately, or share with everybody across the board, because I think this is something we all kind of struggled with. When we talk about, though, the emerging infectious disease, we want to capture what was the process we used for screening, what were the treatment protocols that we developed and utilized. So if you utilized any of the antibody therapies, in either the monoclonal or now the two dose therapies. Did you develop a process to document things in the EHR? Did you have a process to rapidly isolate and quarantine people? Did you have a process for who wore PPE and when? Did you have visitor policies? Did you have transfers to other SNFs as a result of that? So all these things could be kind of built into that kind of category on emergent infectious disease, and how you captured that information and instituted it into your relevant plans. All right. So we've kind of got to the end of that. There's going to be some folks that really struggle with mass fatalities. I don't want to concentrate on that. It's such a depressing topic, but there were a number of facilities, especially within Los Angeles County, that struggled with this in December and January. So if that was indeed a problem for you, I would not mind that you captured this on the form, and especially if you had to hold a multitude of bodies for many days at a time. We definitely don't want to do that if we can all avoid it. And generally, when we have to hold fatalities like that, it's not, we have not really thought of it in terms of a pandemic. We thought of it, in terms of God, there's a earthquake and part of the building collapse, and we're stuck and nobody can get to us, and then we have to hold the fatality until the roads can be rebuilt and things like that. But this was just a massive number of people that were dying, and there were just not enough places to put them. And that happened in other parts of the country. It happened in Los Angeles, sadly. It didn't happen so much outside of Los Angeles, but definitely if you struggle with mass fatalities, you can include that as one of the objectives and activities you want to take a look at. How you dealt with it, did you identify any strengths, and what were the weaknesses that you identified? And as an improvement plan, this is going to be one of those things, is maybe we have multiple relationships with other, besides just a coroner and one funeral home, maybe we have multiple funeral homes in our kind of Rolodex to call. We also want to maybe have some body bags or some kind of storage bag on site in our pandemic supplies. Hopefully you don't need that many of them, but man, if you had a box or case of those to keep with your PPE supplies, it might be a good improvement plan for that. All right, let's talk about so how do we do the improvement plan? This is the meat and potatoes, guys. This is the most important thing. Yes, we identify where we had strengths and weaknesses, but how do we get better, and how do we identify what we want to do? So we're going to do the same thing. We're going to list out the core capability from that handbook, one of those 4 capabilities that it applies to. We're going to type in our area of improvement. What do we think we're going to do? And then we're going to type 3 corrective actions. Now, how lengthy or detailed those corrective actions are, that's up to you. But it should be 3 things that we want to accomplish, or 2 really small things and 1 really big thing. But we definitely want to put 3 things we're going to accomplish. Where it says capability element, there's a handout on the side that says TCL.pdf, and that has all those capability categories. You can pick what category the corrective action most likely aligns with. This is a little bit more difficult to read that information, but once you say, okay, my corrective action is going to be increase fit testing at my facility, and the next corrective action could be about purchasing a qualitative fit test kit from our vendor. And the 4th one could be training, or the 3rd one could be training 3 staff to perform the qualitative fit testing on site. So that's an example of kind of 3 things and how you can document them. That capability element, you're going to look for the one that talks about PPE or worker safety, and we'll put that element in there. And then who's the primary responsible organization for completing this? This in our specter, this is going to be us, and it's always going to be us. We should not be identifying improvement plans for other folks. That's their purview, and we really have no control over how well or how poorly they do their improvement plan. We can only take ownership for our own, and that's the only thing that you're regulatorily required to do. So primary responsible organization will always be us, or always be you. In terms of the organization point of contact or POC, that's just going to be the person whose name is responsible for making sure that all these things are done. So that's the person that's taking ownership over that, that improvement plan. You're going to put a start date for your improvement plan. And what I want you to do is I want you to give yourself 60 days to complete that improvement plan. And then once it's completed, you're going to go in there and document that it's been completed. You can totally see getting started on this, picking a start date and getting fired away. And you start on your plan, and you know, survey comes in, and this completion date is not documented. And you could do all that work and then get a deficiency for not signing off on this. So just as important as all the really meaty stuff is in here for survey, it's important that we document this the way they want to see it documented. Otherwise, they're going to give us a deficiency for something that's not a deficient practice. All right. With that, I want to kind of hop to questions if folks have got anything. Hopefully that explains the after action reporting and improvement planning process. I've given you some ideas of you know, where I think strengths and weaknesses lie and where I think we should focus on. What are some easy improvement plans that I think you guys could do? But I think you've got kind of the gist of it. Now, with that being said, we traditionally on this webinar, we like to bring you the updates from CMS, if CMS has any emergency preparedness updates. But because because normal surveys are beginning right now, and the CMS reg changes weren't hugely different, there were some differences. I wanted to get this after action report and improvement plan in your hands, and I want you guys to get started on that. If you get a survey, you know, a life safety survey, an emergency preparedness survey, you should have already get started on this. And you're coming up for survey, you really got to get started on this process. Because I think it's, I don't want to say you get a deficiency if you haven't started on it, but certainly the expectation is that the reason why we do this after action report is, or the reason why we're doing it for the response, for survey anyways, is because we have a requirement to do a disaster exercise. If we're in an actual emergency, as long as we do the after action report, we don't have to do the exercise or the documentation from that exercise. But because that exercise wasn't held last year and it's not going to be held again this year, they're really going to be focusing on whether you have this after action report. So it's important that we got to fill it out. The better we do at this, the better look and the better information I will have to kind of approach these folks and go, look, we got to do this better next time. And this is where the gaps are in health departments. And these are where the gaps are at our state public health department. Without these after action reports, I don't have the data to be able to approach somebody and say, these are where the failures are and this is how we can fix them. All right, so with that being said, the CMS did have some updates to their emergency preparedness requirements. Those updates we did a webinar for those updates. They're on our CAF YouTube page. If it's was recorded on May 7th. So if you look for the webinar, I actually think we uploaded on May 10th. But anyways, if you're interested in learning about that, the changes to the EP regs, they didn't add any new tags, but they definitely had an expansion of some of the requirements around generator fuel, what the expectation is. You know, if your facility was built after 1991, there's some information on safe temperature range, a bunch of stuff. If your generator is built in 2010 or newer, you have to have 96 hours of fuel on site. You know, it's things like that. There are some fairly significant expansion of the tags. So if you want, or if you can't find the link to that that webinar, just send Summer an email or myself, and we'll send you the link to the YouTube page. You don't get CE on the YouTube page, but you do get all the information for free. There's a ReadyNet training. The reason why I said all that is because one of the things that CMS really highlighted is this process being able to share information back and forth, this kind of bi-channel information between you and the response agencies. That's been a really sore spot during the response, so it's been tough. With that being said, in Los Angeles County, we don't have great, not everybody's in ReadyNet. And let's put it this way, ReadyNet is by far the #1 way to communicate with Los Angeles County during a disaster. So in order to do our situational reporting, in order to do our resource requesting, in order to do all that stuff, the primary source of communication for Los Angeles County EMS is ReadyNet. And Los Angeles County EMS is the provider or the MOOC for us in the county. And so when they do bed polls, when they ask for sit reps, things like that, it's all done through ReadyNet. If you've not signed up through ReadyNet, you got to get signed up. It is a part of the CMS requirement to have a process to be able to share information back and forth. Los Angeles tells you that process we want you to use is ReadyNet. So we haven't seen a lot of surveyors ask questions like, are you signed up with ReadyNet? What's your process to share information with the county should they need it? But that was a big focus on the explanation to the changes to the EP regs. So expect there to be some focus on that as well. If you've never signed up for ReadyNet and you don't even know what the heck I'm talking about, there is a introduction to ReadyNet. It will be on June 3rd, 2021. You can register for the webinar there. It's free for anybody to attend. If you're already signed up with ReadyNet, please update your contact information. If your facility has a ReadyNet account and you're the administrator, but you're not listed as the contact person, you need to go in there and change it and make sure that the correct person is listed in there. All right. All right. Oh, there's I knew I added it in there. God, I'm good. Okay, so the webinar for the CMS updates is linked right there. You can download that at any time. I apologize, I rambled on. I'm gonna try to get to questions here in a second. All right, so we got questions. Oh, please remember to include business continuity plans in an after action plan. So if you have activated business continuity plans, that would be another good thing to take a look at. I forget what objective and activity that's listed, but it is listed on one of those objectives in the template. I'll have to go back and look and see which one it's listed under. Some of this terminology, as you read that handbook, is really difficult. Or you're going to read these kind of activities in that handbook, and you go, well, this applies to all organizations, and so not just us. It's not the greatest thing in the world, and it's certainly not written just for healthcare facilities. So let me see if I can find that, the objective that you would want to. Yeah, okay, so under Objective 2, Plan for Continuity of Operations, Activity 1, develop a healthcare organization continuity of operations plan, or business continuity. A lot of times they're called very similar things, but the idea is what are the operations that need to continue for us as a business to be able to support our ability to provide care. It's not just providing care. It's it's taking payments. It's paying people money. It's buying things. It's all that other stuff. So, all right, guys. Well, we've had a fantastic hour. This will be recorded. So if you've missed something or you go, man, I got to go back and check and see what that said. You can do that. We're gonna include or put this up on YouTube. So maybe in a couple of days it'll be back up on YouTube so you guys can watch it. And with that, I want to say thank you very much for joining us. Summer, you got anything you want to say to the attendees before we let them go?
Thanks for attending, everybody. I'll hear from you guys soon.
Yep. Thanks very much, Jamie, for pulling all this together. If you guys have any questions, there's my email. Don't hesitate to reach out to us. And with always, thanks very much. Take care.